Okay, let's dive right into this explainer. We're going to take a VIP, behind-the-scenes look at the rigorous safety protocols used to navigate the hidden risks of modern keyhole surgery. We'll be unpacking a fascinating review from the journal Advances in Therapy that maps out exactly how gynecologic surgeons keep their patients safe during these incredibly intricate procedures.
You know, laparoscopy is widely considered the absolute gold standard in gynecology. It offers reduced surgical trauma, way less postoperative pain, and a much faster recovery time compared to traditional open surgery. But while it brings all these incredible benefits to the table, we really have to ask ourselves, what happens when surgeons face unexpected anatomical minefields? Because the reality is, operating through tiny little incisions while relying completely on a monitor requires just immense skill. And complications, while they are rare, can be pretty severe.
So take a look at these numbers, 0.69% to 6.22%. The crucial point here is that this is the baseline complication rate for gynecological laparoscopy. It really grounds the stakes in hard data. To break that down a bit further, major complications, the kind that actually require additional surgical intervention, happen in about 2.84% of cases. Now, understanding these numbers isn't about creating fear at all. It's really about appreciating the incredible precision required and the super strict safety rules that exist to keep that percentage as low as humanly possible.
Because this subject is so complex, here is our surgical flight plan to ensure we don't get lost. 1. The promise and the risks. 2. First steps and entry complications. 3. Navigating the bowel. 4. Guarding the urinary tract. And finally, 5. The vascular danger zone. Let's get to it.
Section 1. The promise and the risks. This establishes our landscape, where a surgeon's experience directly correlates with minimizing those severe risks.
Moving right along to Section 2. First steps, entry complications.
Now, what's fascinating is that just getting inside the abdomen is widely considered the Achilles heel of the entire procedure. It literally accounts for over 50% of all complications. So, surgeons have to rapidly weigh the pros and cons of 3 distinct entry methods. First, you've got the Varus needle. It creates a nice protective gas cushion first, but it involves a blind insertion, which means it can fail or misdirect. Then, there's the Hassan open entry. This allows surgeons to physically see the tissue layers they are cutting through. That really lowers the risk to blood vessels, but it's slower and carries a slight risk of nicking the bowel. Finally, direct entry. It's incredibly fast, has a lower failure rate, but wow, it demands really high technical skill. There's actually no universal mandate on which one to use. It all comes down to the patient's unique anatomy and the specific expertise of the surgeon.
And patient positioning is a huge deal here. Patients absolutely must remain flat at a 0-degree angle until that very first trocar is inserted safely. Why? Well, it protects the major blood vessels, keeping them safely tucked away. If you tilt the patient head down into that steep Trendelenburg position too early, gravity actually pulls the internal organs upward. That exposes the critical vascular structures right near the spine, drastically increasing the risk of a catastrophic blind injury.
All right, Section 3. Navigating the bowel. This is where the anatomical minefield really builds.
Here is a wild statistic. Up to 50% of bowel injuries, which are often caused by physical trauma or hidden electrical burns, remain completely undetected in the first 24 hours. The intense magnification of the surgical camera can sometimes limit peripheral vision, so a microscopic electrical burn on the bowel might go totally unnoticed until the patient gets really sick days later. So how exactly do surgeons double-check their work and spot a hidden intestinal leak?
They use a brilliant diagnostic trick. By submerging the loops of the bowel or using a striking visual reveal, they can immediately unmask those invisible perforations. They might fill the pelvis with fluid and pump a little gas into the anal canal to look for bubbles, literally exactly like finding a tiny leak in a bicycle tire. Or they'll inject this incredibly vibrant methylene blue dye. If that blue color bleeds through the tissue, boom, they instantly know there's a hidden muscular tear that needs immediate suturing before they wrap up the surgery.
Shifting deeper into the pelvis, we hit Section 4, guarding the urinary tract.
Surgeons have to meticulously expose the specific white reflection line to separate the bladder from the vaginal wall. This is a highly delicate process, especially crucial in patients who have had prior C-sections. Previous surgeries can create tough, fibrous scar tissue that practically binds the bladder directly to the uterus. If the surgeon doesn't identify that specific gray-white plane to gently push the bladder out of the way, they risk accidentally opening it right up.
And the ureters? They are incredibly vulnerable to electrical burns.
Normally, the ureter naturally pulses, kind of like a heartbeat, to move urine along. We call that vermiculation. But if a surgeon gets just a bit too close with an ultrasonic or bipolar energy tool, the heat can radiate and essentially cook the ureter. It freezes up, stops moving, and turns stark white as the blood flow is compromised. Tissue whitening and that sudden stop in movement are immediate, glaring red flags of thermal damage.
When the ureter is compromised like that, a strict procedural checklist is immediately deployed. This is absolutely critical to prevent postoperative fistulas or even the total loss of kidney function. The surgical team will jump in and place a preventative double J stent to keep the ureter open while it heals, leaving it in there for 6 to 8 weeks. They'll also insert a Foley catheter for 10 to 14 days to drain the bladder and relieve pressure. And if the damage is complex, they call in a urologist on the spot for a full reimplantation.
Finally, we reach the grand finale of our journey, Section 5, the vascular danger zone.
While rare, vascular complications are honestly the most feared events in the OR, and they are the leading cause of surgical mortality. We're talking specifically about the right iliac and inferior epigastric arteries, which are highly vulnerable during blind trocar insertions. A shocking 82% of all vascular injuries happen right at the beginning, during the initial abdominal entry. To avoid catastrophic bleeding, tools must be placed perfectly within designated safety zones, about 2 to 3 centimeters above the superior iliac spine. Go slightly off course, and you risk hitting those major hidden arteries.
So how do they navigate that? They use this genius technique called transillumination. The surgeons literally take their internal camera and press it right up against the inside of the abdominal wall. The bright light glows right through the patient's skin, clearly outlining the dark shadows of the hidden blood vessels. It essentially gives the surgeon a real-time roadmap to completely dodge the danger and safely insert their tools into the avascular gray zones. It is so cool.
So I want to leave you with this provocative thought. Considering the absolute incredible precision required to navigate this anatomical minefield, isn't it amazing the skill it takes to perform these everyday miracles safely? Every single step, from the moment the first needle touches the skin to the precise manipulation of delicate tissues deep inside, is governed by a complex checklist of anatomy and physics. The next time you hear about someone having a quick laparoscopic procedure, you'll know exactly what kind of masterful balancing act is happening behind the scenes to get them home safely. Thank you so much for joining us for this explainer, and keep asking the big questions.